Good morning.
Oh, morning. How are you, Edward?
Thank you. How are you doing?
Oh, very well. Thank you. Very well. Thanks for joining. I thought it will be what you call good to just check it early on.
Yeah.
And usually I used to have a capacity for 500 people, but it rarely went to that number. So I reduced to 100. And so now we have about 125 uh, registrants. Usually about one third attends, but in the very unlikely that all of them attend, and then it will be difficult to bring you in. That's why I thought, just to be on the safe side. Shall I just make you?
Guess what?
I'm just going to make you so that you can share your presentation.
Okay. Let me know when it's okay to
Should be
proceed
now.
to that.
It should
All right. Now, I always screw up whether I do um, sharing or not. So I'm going to try this one, and you tell me if you see um, the. Do you see my little leading screen or just one thing?
Yes, you are now. I'm seeing your presentation mode, not your usual uh, one screen, one big screen. It usually happens if you have, I think if it usually happens if you have two screens going.
Yeah. All right.
Now I can see one. Yeah.
Right, but this is just where I can't see a leader and you can't see a leader here either, huh?
Here I can. So the one that you initially showed the slide and all the slides on the side. It didn't. It didn't have the full screen.
Yeah. I never know how to do this on Zoom the right way. Um,
Do you have two screens?
no, I just have my laptop here.
Oh, that should
Uh,
be.
so, I mean, I can make it work without it. It's always nice to have the presenter view, but I've never really figured out how to do that.
So
Uh,
if you and you are on full screen on your PowerPoint, are you? You are, aren't
I am, yeah, yeah.
and when
Have
you are
you ever? Sorry, go ahead.
when you are on the full screen, we are having are you on did you press F5 function 5 presentation mode, or are you putting on presenter something mode?
Well, I was working on presenter mode, which is what I prefer. I just don't know how to project that.
Oh,
Uh,
yeah. If you're on presenter mode, then it will project the presenter, the whole screen, I think.
yeah. Um, let's see from Zoom if there's any. Hmm.
It's going live, so just to let you know if that's okay with you.
That's okay. I won't say any bad words.
Thanks. Thank you.
But we're starting at 8, is that correct?
Yeah, we are starting in 15 minutes, isn't it? But
Okay.
I'm just so that otherwise I will find it if this way I'm already started. Otherwise I find it hard to get it going. That's
Mhm.
I haven't myself ever figured out between the present and mode. And usually I got a two screen, but I'll stop one of them off because otherwise it gets into that trouble. I don't know if you have two screens, you can do it.
No, I just have my laptop.
Uh, I know I'm just wondering whether if you had two screens, whether you can. Or if shall I just quickly Google and find out? Just a second.
Well, I'm doing that as we
You
speak,
are
actually.
because usually it should have the answer.
Okay, so in the PowerPoint, select the slideshow tab, set up, excuse me,
That's it.
set up presenter view. Okay.
Mhm.
Uh, okay. Set up slideshow. Okay. And we're getting there. Let's see.
Oh, no problem.
Browse by individual window. Hmm. Okay, browse by an individual window. Okay,
Mhm.
try this manually. Yeah, taking out a cavernoma with brain surgery is easier than running the computer. All right, now under show type, yep, start the Zoom meeting. Select share screen, Microsoft PowerPoint, share, and then presenter view. Okay, so now we go to Zoom. We go to share screen. Now what am I feel like an old man now. Okay.
Oh, no, don't worry. I've been doing Zoom for years, but every time I come, it's a revelation still.
PowerPoint, got it.
Mhm.
And then what we want is presenter view, share. PowerPoint, click presenter view. Okay,
Mhm.
this will take an hour here just to get this going.
Yeah.
Okay, slideshow, click presenter view. All right, what do you see now?
Let me just have a look. Just a second. So I'm still seeing the presenter view. I'm seeing
Ah, how disappointing. Uh,
now I'm seeing once again a shorter presenter view in the sense that one slide and one and and the side of the slides going on the side.
Zoom, there should be a thing new. I don't, all right, well, I'm just gonna do it without then. I've done worse things in the past.
I tell you, if I have, as I said, I have not figured it out. I will try to figure it out, but I'm sure there will be some. But Zoom has kept changing the goalpost. It has tried to move, create new things all the time, and it has been difficult to keep up with it sometimes.
Yeah. Um, all right. Well, we got another minute or two. You said there's
We have got 10 more minutes, so we have
all
got
right.
plenty of time.
Well, I'm gonna keep fiddling with this while I can, and then until that time, you give me the warning, and then I'll zip my lip here.
Oh, no, no problem.
How are you these days? Where are you physically these days?
Physically in Southampton.
Nice. And how's the weather in Southampton today? We're getting the outer winds of the hurricane even way up here in Massachusetts
Oh,
these days.
yeah. No, we don't have hurricanes, but we always, and this is supposed to be the Riviera of England, the sunniest part of England. That means we got about 15 days of sunshine in a year. So it's an overcast day today. To be honest, it's a good weather. It's so you can't do much, so you have to do something. Uh, and to be honest, this boring weather is nice because just north of the town, north of England, or middle of England, there was so much rain and flooding, and cars are submerging in water. So to be honest, I will pick this weather any day.
Yeah, we had beautiful weather for a little while, but it definitely has turned a little for the worse this morning.
Yes,
Let's see.
this is the best you get in England, this weather. So
Well, you take what you can get, right?
Yes, exactly.
No, that's not going to do it.
I didn't realize you were quite close to New York, same distance as.
Relatively, yeah, about 180 miles. So, what, 200 and almost 300 kilometers.
Yeah. It's the same distance as going from here to Manchester, where I used to work. So I don't, we always think when you say different states that they are so far apart, but not really in the Northeast, I take it.
Yeah, I mean, we go there a fair bit. I went to medical school in New York City, and we used to take a train since I lived here in Massachusetts, and it was always a little bit of a, interesting back and forth.
Mhm.
Uh,
You're
but
from you're from Massachusetts, are you?
I am, yeah, I just grew up about an hour south of the hospital,
Oh,
so I'm fairly local.
oh, that's fabulous.
Yeah, it's nice. So we still have a lot of family around, and it really helps a lot.
Oh,
Um,
fantastic. I mean, that's amazing. Very unusual in America to be so close to where you grew up, isn't it?
yeah, my wife's from upstate New York, but she gets sort of stuck seeing her in-laws, my family quite a bit. So
Yeah,
uh, you know,
that's lovely. That's good.
let's see.
Yes, I've got an introduction on you, so I've dug up about you. So it's a 9 slide
Oh
introduction.
golly,
Exactly.
that's scary.
No, there's nothing controversial. It's all.
As long as there's nothing that I might get arrested for, that's probably pretty good.
No, it's all good.
All right.
So that
Am I sharing a screen right now?
let me just have a look. Just a second.
Oh, 1 second. Let's try this guy.
Oh, yes, that's brilliant.
Okay.
That's only one slide.
All right, and that's working for you?
Yeah, that's working. Yeah.
Okay. All right. So if I sort of click through it now, it is clicking through on your screen with just
You have gone back to your own camp. You have just unshared it. Uh,
oh crap.
yeah.
All right. Uh I've unshared it. Oh, what a bad man. All
Sec.
right, let's try this again. So this is you're seeing everything now, right? And now you're seeing a little advancer things.
Oh, now we are back to the presentation. Um, we are now back to presentation thing.
Okay. This is back to normal now.
Yeah, this is now full screen. Now you are going back. Yeah.
But if I get out of this, can you still what are you seeing now?
Now we are back to presenter mode.
Oh, boogie. What a pain in the can.
No problem.
All right. Well,
I'm having my troubles here. I'm trying to. Oh, it's recording. Good. If it was easy.
all right. Well, I will just wing it.
Yeah, it's usually you'll be fine.
I'm terribly nervous, as you can tell. The sweat's pouring off me.
You'll be absolutely fine. Only when I was a resident medical student, I always sat on the front seat at any place. But now I sit in the last seat. Yeah. It's amazing how one has changed.
Well, that's it's good that you still go to conferences. Sometimes I don't even go to the conference, so you're one up on me.
Oh, I'm rarely going, but I'll be seeing you in Toronto in a couple of weeks' time, or less than a couple of weeks.
No, actually, I'm going to be visiting professor in Kathmandu.
Oh,
So
really? Oh,
yeah,
no,
so I'll be off in Nepal, and then I'm
it's lovely.
staying after with my wife, and we're going to try to do the Annapurna circuit.
Oh, wow, that will be fantastic. I always wanted to go to Nepal, but not been there yet.
No, me neither. I'm very excited about it. I'm framing it a little bit as a sort of a we've been married 30 years coming up, and so a little bit of a
Congratulations.
quasi 30 year. Well, she cries a lot, but it works out.
That's fabulous. What do you call no Nepal should be fantastic.
I hope
Uh,
so.
and
So
then
I'll see you in
I think
Toronto, but
I
you
think
know,
while you are in Nepal, I'm sure I think that this is a family visit. Because, from what I have seen, Nepal's neurosurgery is advanced, but not so. They still have they will be keen on pediatric neurosurgery because, Nepal and Britain has a close link, but the pediatric neurosurgery is still not established in any way, as far as I know. I'm open to be corrected. So I will, as I said, it's your holiday, but I'm happy to put you in touch with Dr. Let Dr. Sharma contact you if he wants.
well, that'd be great. I think Mr. Henry Marsh might be over there. He had emailed me
Okay.
about one of his proteges, very nice gentleman named Cigar, and he came and spent a few months with us at Children's in Boston.
Oh, good.
So it's been nice.
Oh, that's brilliant. Thanks. I think we are almost there. Is it okay if I present my introduction to you? And
Please, you're the boss.
thank you.
So let me stop sharing.
Please, thanks, if that's okay. So let me just see whether I can share my side. Let's see. Okay. I have updated to the latest Mac OS and Mac operating system, and it keeps um, asking permission for everything. Okay, good. Can you see my slide?
Yes.
Oh, brilliant. So let's see whether, yeah, we are exactly at 1 o'clock. So welcome to everyone to this master class in neurosurgery lecture series. And today we have the honor and privilege of having a lecture on pediatric cavernoma from Dr. Edward Smith. It's a great honor and privilege to have Dr. Smith with us. He's an acknowledged leader in this field. And before I introduce him, I just want to go through a few house keeping um, notes. Um, at the end of the lecture, after the discussions, I will put the link for the feedback form. For those who complete the feedback form, you will get pretty much as soon as you submit a certificate email to you, and it will as a email to you, it will have the certificate attached as well as a link to the quiz. And then later on, I will send you a link to an interactive recording. When I say interactive recording of what I mean is a video, but in the video there will be quiz. So you can ask yourself before you go to the section and so on. So it's a more interactive, and you can put questions if you want, and I will forward it to Dr. Smith, and hopefully Dr. Smith will answer them. So it's a more usually when it's in the YouTube, it's pretty much you put it there, but this is a interactive platform. And also, I will also get you the transcript. Sometimes always nice to read the lecture. So we'll also email you the transcript of the lecture as well. And during the lecture, if you could please keep your video and your audio on mute, that will make it easier. I will try to keep mine mute most of the time, but sometimes it's good for Dr. Smith to know that I'm there. So these are just the housekeeping notes. So now it gives me great pleasure in introducing Dr. Edward Smith. Um, Dr. Smith, as most of you would know, I'm sure all of you would know, is coming from Boston Children's Hospital. If anyone wondered where Boston is from New York, at least according to Google, it's 217 miles. That's the same distance I used to travel from Southampton to Manchester. So it's not that far, but for me, it used to take 4 hour drive. And so, although different states and crosses a few states, it's not that far. And Boston Children's Hospital, but everyone in pediatric neurosurgery knows of it. And and it has, for the last few years, or the years that I have known, tried to be on the top of the US news rankings for neurology and neurosurgery. So it's a place to compete with and hopefully to one day beat. And In terms of Dr. Edward Smith, he did his medical school in Columbia University, New York, which has been one of my favorite universities in the last 6 months, with all the good students there. And then he did his neurosurgery residency in Massachusetts General Hospital. I could never quite say it. So, prestigious residency associated with Harvard University. Then he did his fellowship at Boston Children's in pediatric neurosurgery with, among others, Dr. Michael Scott. And and currently he is a consultant neurosurgeon at the Boston Children's Hospital, and he's a co-director of the Cerebrovascular Surgery and Intervention Center. And with the Harvard, he is R. Michael Scott Chair in Neurosurgery and professor at the Harvard Medical School. And he has been prolific um, in his contribution academically as well. In PubMed, Edward R. Smith has a 270 publications. I don't know how much that I have missed out. Google Scholar gives an impressive H index of 41. That means that 41 of his papers have been cited by 41 other papers, which is amazing. And the I-10 index is 72. 72 of his papers have been cited more than 10 times, which is pretty amazing. And earlier in the year, he published a review article in the Bible of Medicine, the New England Journal of Medicine. So we have the right person for us to give us this lecture. I met Dr. Smith back in 2009 at the WFNS Congress. And I was introduced to Dr. Michael Scott, to Dr. Smith by Dr. Michael Scott. Sadly, he passed away earlier in the year, doyen of pediatric neurosurgery, and ever since I have um, worked with Dr. Smith, and he has contributed in several ways to the listserv. So I'm very grateful to Dr. Smith for all the collaborations and contributions to the listserv. So without further ado, I give the podium to Dr. Smith. Thank you, sir, for giving us this lecture.
Well, thank you. It's an honor to be here, and it's always a pleasure. I'm going to talk today about cavernous malformations, and we'll see if we can get this started here. Can you see the screen okay?
Yes, looks fine, absolutely fine.
Great. Well, I don't have any disclosures to make. And I thought I would start with sort of the clinical side of things and then move in a little bit because the area of research is so exciting in this. So, to start with the clinical side, when people talk about cavernous malformations, again, even from the patient standpoint, these questions come up, what are they? I think anytime we have any pathology, it's incumbent on us as physicians to say, why they're a problem, to define why we treat them. And then for those of us specifically in the surgical world with treatment issues, I think we have to understand as best we can the natural history so that can inform intelligently who gets picked for surgery and what those indications might be. So I'm going to try to do the best I can to summarize the knowledge for that before jumping into the science world a little bit. So I know many people know this, but these are sort of people have described them as looking like mulberries. Now, to be honest, I've never seen a mulberry, but they're these sort of multi-lobulated little blobs. They occur in the brain. They sometimes will have a developmental venous anomaly next to them. They'll have this hemosiderin around them, which I'll talk about in a second. And they can come in either a sporadic form, which can be after radiation or spontaneously, or they can be a genetic form with these three genes, which I'll talk about in a little, CCM1, 2, and 3, not very imaginatively named. Um, Basically, they are slow flow. So these are not like an AVM or an aneurysm, and people know this. They're not going to rupture. They're very common, affecting about 0.5% of the population. So roughly 1 out of 200 people will have one somewhere. They're essentially immature vasculature. They're largely endothelial cells. And one of the big problems, and we'll talk about this at the science part in a little bit, is that they don't stick together really well. And as a consequence of this failure in cell-cell adhesions and smooth muscle cells, they create these bubbles like the mulberry I showed you on the prior slide, and you get this leaky endothelium. And that's the hemorrhage we see as physicians that affects our patients. Importantly, a big advance recently has been this growing understanding of the role of the microbiome, where the gut has gram-negative bacteria. The gram-negative bacteria make lipopolysaccharide that circulates through the body and stimulates toll-like receptor 4, this TLDR4, which is a receptor on endothelial cells. And this is important because it can interact with this protein complex of these CCM proteins, and that can basically screw up the cell. That's a fancy Harvard term. But this is really interesting to see this gut-brain interaction, and we'll talk a little bit more about that more. Most of these are sporadic. They're solitary lesions. But about 30% of cases may have an autosomal dominant mutation, and these typically have multiple lesions. And again, the genes and their corresponding proteins are CCM1 with CRIT1, CCM2 with OSM, and CCM3 with PCDC10. And those three genes, the mutations in one of those, comprise about 90% of all the familial cases. Just to sort of go over this, and again, for the trainees, this is a very important boards question for exams, but for the understanding of the genetics, I think it is important to know this. So CCM1 essentially inhibits this kinase in a normal state. And so when you have this mutation, this kinase gets overactive, and this fiber of actin basically becomes too active, and you lose connections between cell-cell junctions. And this is why these things leak. CCM2 also is a complex that regulates these and causes a similar problem. It also, CCM2 affects angiogenesis. This is why these kids may have a little more growth around them. And then CCM3 tends to be the worst phenotype. This affects cell adhesion, but also apoptosis. And this also has a big role in the gut as well. So of the three, CCM3 tends to be the worst. They're a problem because they bleed. This is a spinal cord malformation. You see this tiny little dot here. No one really was sure what it was, but then it bled. And even though it's not a huge bleed in a sensitive area, as all of you know, this can cause significant problems. So if that's what they are and why they're a problem, what do we do about them when we find out somebody has them? So these things, these cavernous malformations, are rare, and there's very limited data on the natural history, treatment, and outcome. And so one of the things we've tried to do, at least here in the US, and I know many other places as well, is to really create guidelines that are based on evidence. So we have our recent American Heart Association guidelines for the Stroke Association that just came out in 2019, and then we have just submitted the new Angioma Alliance guidelines, which hopefully will be published in early 2025. But it really shows how limited the evidence is and why we need these kind of meetings to promote this research. We've looked at the natural history and tried to understand who the right kids are to treat. What we found is that kids very likely are to present with hemorrhage. That's the most common in about 62% of kids. That will overlap somewhat with seizures. And then even about a quarter of kids now in the US present incidentally, and we seem to be finding these after scans for other reasons like trauma. The vast majority of them sort of mirror their location based on the volume of the brain. So again, about 3/4 are supratentorial, and the remainder are mixed between the deep basal ganglia, the cerebellum, and the brainstem. So no real surprise in terms of location. We get new ones essentially that show up roughly about 0.6% per year, and that's per lesion, and about 0.4% per patient. So again, this is how often we find them. And for kids with familial or radiation, that's at a higher percentage. So if you have someone who had a brain tumor and they've had brain radiation, about 1.5% per year, roughly, will develop CAV-MALs on follow-up scans. A big question we get a lot in our service is, what makes these things bleed? And so there was a very nice paper written by one of our colleagues, Heather Fullerton at UCSF. Basically, there's not much that will stimulate them to bleed. So repeated head strike sports might do it in the US, American football, much less likely in football for the rest of the world, or soccer, given that the head strikes are far less, but we recommend against boxing and things like that. Infection probably does not do that. And blood thinning agents are probably unlikely. There's been a lot of studies on aspirin. So in short, there's not a whole lot that simulates these to bleed. And we let most kids who have these do whatever they want for activity. When they bleed, or how often do they bleed, incidentally, it's pretty low, about 0.5% per year if there has not been evidence of a prior bleed. But if they've presented with a hemorrhage, there's a clustering effect. Dr. Hanjani has written about this from the Cleveland, and then we've written about this a little bit as well. But at the beginning, in the first 3 years, it's as high as 18% per year. So they will tend to sort of bleed. They have this little, cluster of activity, and then it will quiet down after that. So it's important to understand this with watching. This really informs how we do our follow-ups. So, for example, if you say, well, how often should we scan these kids after they've been discovered? Because we have this natural history data, we've usually done a once a year for 5 years. That's reflected in our guidelines here in the US. And then after that, you can see that the bleed and the rebleeding rate tapers off. So we usually diminish our scanning after that to every 3 to 5 years. And this is the reason why we try to explain it with our natural history studies. Another people, to get a little more granular, people say, well, how do these behave in specific locations? And so we looked at, for example, the basal ganglia, and we found that if you have a deep basal ganglia lesion, a lot of them will present with choreiform movements or seizure. Basically, what we found is that if these lesions are growing or they're symptomatic, they're usually amenable to surgery and can be removed. If they're bleeding repeatedly and you have a surgical corridor, you should take them out. But if they're small, if they're not bleeding and they're not symptomatic, we will typically leave them alone. And this is one of the areas that's sort of growing a little bit with questions around lasers, lit and focused ultrasound, not just for basal ganglia, but a lot of deep lesions. And this is an area in evolution right now. Other locations, the very classic one that I think most of us will see are these routine supratentorial lobar cavernous malformations. This is what almost all of them are, as you saw in the previous slide from one of our other papers. About 3/4 of them are going to be like this. Basically, if these kids present with seizure, it's important to understand that just taking out the lesion will result in about an 80% or better reduction or cure of the seizures, and about a 96% likelihood of curing them. So you don't necessarily need to use ECOG or taking out all the hemosiderin. Just removing the lesion alone will really improve their seizure outcome. And I think this is an important point for people to get too aggressive about chasing hemosiderin. The bottom line here is that you can improve their angle scores or their seizure symptomatology just with resection. And I think this augurs that we should remove them. One of the new points in the guidelines coming out this year is that unlike prior years where if they just had a single seizure or a couple of seizures, we might treat them with medicine and not surgery. We've shown, I think, from the evidence that early resection for seizure patients is probably better for long-term control. So the point is being a little more aggressive about these, or just do it, as we say here, with Nike in the US. So we tend to be fairly aggressive about surgical resection if they have symptoms, if they're in a relatively safe location, or if they've had seizures that require medication. Now, we've talked about the natural history and we've talked about how we treat them. As surgeons, I think we should always be asking, how can we improve our treatments or make these treatments better? And so, as surgeons, I think the first easy, low-hanging fruit is surgical advances. How can we get where we want to go to take these out? One of the most challenging areas and continues to be our brainstem cavernous malformations. And this is just one of my very early papers, and a lot of people do this better than me, but I think it's important to recommend and understand that brainstem cavernous malformations can be removed, particularly if they come to the peel surface. This is a fairly routine approach. We've written this up almost 20 years ago, but I think it bears revisiting the idea that you can get to these lesions, and many times they tend to come to the peel surface dorsally, and this is a route by which you can get there. If it comes through to the peel surface, usually getting in there, the cavernoma will create its own cavity, and it really can make these resections, I think, better than you might think they might go otherwise. They're still very high risk, and it still requires careful thought. But if you have a recurrently bleeding lesion and one that comes to the surface, I do think it's worthwhile considering surgical resection in some of these cases. There's also some excellent data suggesting radiosurgery can be helpful for the deep-seated lesions that are recurrent problems, as long as they're not too big. With that, that's sort of a maximally invasive approach. What about being less invasive? And one of the papers we've written up is the idea of ultrasound-guided catheters. So, people routinely use things like frameless stereotaxy, stealth, Brainlab, etc. But with brain shift and with movement of the brain, sometimes the accuracy for this can be off. And if you have a deep-seated lesion, it can be sometimes important to understand that you might miss just with fixed frameless stereotaxy. This is where ultrasound comes in. And so what we try to do is use real-time imaging, complemented by frameless stereotaxy, but really using real-time things, and to get into the lesion directly by using a catheter that's passed down there, which we then can just follow directly down. You don't have to worry about sort of a kludgy heads-up display in your microscope or repeatedly checking with your frameless stereotactic probe. You really can just put the catheter in, follow it right down there, and it's real-time data. How do we do this? Basically, we make our little craniotomy or craniectomy. We see the lesion on ultrasound. We pass a catheter to it under direct guidance. You can actually see it go in, and then you just move right along under the scope. That's an old Alocus ultrasound. We have a new uh, uh, upper sort of higher quality one, and it's really great. This is not a cavernoma, this is a little choroid plexus tumor, but it sort of augurs the idea. You just put the catheter in under ultrasound. You can see the catheter going right in, and then you've got your opening, and it is incredibly fast, and I think much more accurate than some of the shift with frameless stereotaxy. The main point being you set up your microscope perpendicular to the lesion, you just follow it straight down, and it takes you right to the spot with a tiny corridor. We looked at this with some tumors and cavernous malformations. Basically, it only takes about 3 minutes to get to the lesion. Knock on wood, we haven't had any complications with this, and then it makes for a small surgical tract to get down. So again, not rocket science, but just another little innovation that can be helpful, and I really love the ultrasound for this. So, the limitations here, it's only for straight paths. You can't go around curves if you have like a Sylvian fissure or something deep. It's not applicable, obviously, to high flow vascular lesions like an AVM, and they have to be visible on ultrasound, which CAV-MALs certainly are. So this makes things a little bit easier and it can be customized. It's just another tool in the toolbox to try to make surgery for these a little safer. And the deep cav mals are the tough ones, I think. So we've got some surgical advances. How can we apply them? One of the things that I've found very helpful is we are fortunate to have 3D printing at our institution, where for complex lesions, we can send in films and within 12 hours have a turnaround time to get a 3D model. And essentially, we just send the picture in. We ask what kind of model we want so we can get a clear plastic. We can get one with soft tissue that the residents or myself can practice operating on, and we can get multiple different sizes and shapes. Essentially, they will just print this for us. And it's great, not just for teaching the residents, but I think for rehearsing the cases and for difficult things like a brainstem lesion, this is a way we can get in there and really, get there well. This is an AVM, but just to show the idea of how this works, you could very easily imagine this as a cavernous malformation. You can create models that have high fidelity to the lesion. And what you can see is that you can have different kinds. You can have them bigger, smaller, and for the cav mals, a 3D sort of X-ray one. This is where we're showing that during the surgery, you have this very high concordance between the accuracy of the model and the accuracy of the anatomy. So you can see where this big draining vein is. We know that the feeding artery is just going to be right over here, and there you can see the onyx right there. This is very important, and we've used this for brainstem cavernous malformations, understanding where fiber tracts are, understanding where cranial nerves are, and being able to rehearse that prior to surgery. So the takeaway here, I realize not everybody has it, but these can be sent out for particularly challenging cases. Very high concordance between the model and the operative field, 98%. There's less than 2 millimeters variation. And the big thing is we shorten the OR time by about 12%. So this can really help, not just for making the case safer, but for those of you that have, cost-conscious hospitals, we can save some money. And we've published this, but really helps with teaching. Now, I've talked a lot about the clinical side of things, why these are problems, who you operate on, how they help with seizures, the natural history. But other than these technical advances in the operating room, I think it's very important to understand as neurosurgeons how else we can advance the care of patients with cavernous malformations. This is a little picture of me in my lab. I'm good at thinking outside of the box, but they like to keep me in the box. That said, there's been a lot of new advances, and cavernous malformations, I think, have really been the beachhead for some of these exciting advances in science. Drug therapies, I think, are, if not imminent, very close to coming around the corner. As I mentioned earlier, CCM1 and 2 in particular are very involved in the aberrant regulation of these Rho kinases. Essentially, mutations in CCM1 and 2 jack up the activity of Rho kinase. It's overactive, leading to these endothelial cells contracting abnormally and moving around. And so creating these inhibitors have been incredibly hopeful as a drug therapy to reduce the growth, increase the strength, and reduce the bleeding of these. Anti-inflammatory therapies have been thought about. People have talked about beta blockers and propranolol in particular. The idea here being that there is a direct anti-cavernous malformation effect, in addition to perhaps for adults lowering the blood pressure a little bit as a possible secondary effect. Blocking thrombospondin as an anti-angiogenic therapy has been proposed, and atorvastatin, these statins that are used for high cholesterol also seem to have some effects on reducing the hemorrhagic rate of certain cavernous malformations. The main point here is that there is a ton of hopeful advances on the drug therapy world, and this comes from the molecular understanding of these malformations, which really has been at the vanguard, I think, of cerebrovascular neurosurgery. The other thing I mentioned earlier is this idea of the diet, and in particular with CCM3, the mutations in some of these binding proteins exist, and one of the kinases is called MEC3, and this has been very, very important, not just in the brain, but also in the gut. Kids or patients with CCM3 will often have problems with a leaky gut. This is important because the stickiness, the intercellular adhesion mechanisms that are aberrant in brain cavernous malformations in CCM3 mutations also seem to affect the gut. This is doubly important not only because it affects the gut as a functioning organ, but as I mentioned earlier, the gram-negative rods that live in the gut normally as part of the microbiome will create this lipopolysaccharide. If the gut is leaky, the lipopolysaccharide from the little gram-negative organisms in the gut will leak into the blood. It will swish around in the circulation. And the consequence of that is it will get up into the brain where these cavernous malformations are. They have these TLD4 receptors, these toll-like domain receptors, and the gram-negative proteins will attach to this receptor, and that will augment or worsen the risk of bleeding. So there's been a lot of thought around how you might adjust the microbiome or treat the CCM3 mutation to reduce the risk of bleeding. And this is thought to be at least possibly a contributor to additional bleeding in the CCM3 people and why their phenotype might be more aggressive. Vitamin D3 has also been talked about as a potential agent, and it's probably not important for most people that live where they get a reasonable amount of sunlight, maybe not in the UK, with a little few clouds, but certainly in places in the Nordic countries, for example, where there may be long periods of darkness due to the tilt of the Earth, or anyone who doesn't get good vitamin D3 levels, that's certainly something to think about. Now, I've talked a little bit about what's in the literature for new ideas, but I also like to, in the second half of this talk, share a little bit about how we're doing research to advance the diagnosis and treatment of cavernous malformations and all vascular malformations. And one of the things I've been very interested in are these things called axon guidance factors. And so, just to put it very simplistically, because I'm just a dumb surgeon here, these are proteins. They are secreted, which is very important because you can measure them and manipulate them in various body fluids like blood, serum, spinal fluid, urine, etc. They are chemicals, proteins that are normally part of brain development. These sort of build brains, they build blood vessels, and historically, most of them are supposed to shut down after the birth process because they've done their job, they've built the brain, and they should essentially turn themselves off. They're very important because they do these jobs influencing migration, influence invasion of these growing neurons and blood vessels, and angiogenesis. And the reason that's important is these same mechanisms that are so important to build a brain in a good way are also the very bad things that occur later in life pathologically in brain tumors and in vascular malformations. And the reason this is clinically potentially important is because many of these axon guidance factors work in pairs. There's an agonist and an antagonist. So if there's a good guy and a bad guy, if you can figure out who the bad guy is, you might be able to leverage that to create a treatment that would emphasize the good guy. These are some of the canonical proteins, and I want to focus a little bit today on this one called ephrin, and there's a whole bunch of different ephrins, but these are the guys that are involved in blood vessel growth. Um, and again, these are critical to neuronal and blood vessel patterning. They bind to specific receptors, and they really are involved in vessel sprouting and remodeling. And I know I'm getting a little bit in the weeds here, but basically there's ephrin B2, which is the ligand, and then ephrin B4, which is the receptor. So B2 connects to B4, and then B4 goes through the cell membrane and makes stuff happen. And I know this seems a little nerdy and sciencey, but I think I can bring this home to show that part of the reason this is important is what we observe as clinicians. Dr. Scott, Nara mentioned earlier, my mentor, Mike Scott, and he was not a scientist. He didn't have a lab, but what he did have was a very keen sense of observation. And what he noted was what happened in the clinical world. When you talk to scientists about ephrins, what they'll say is that these are the proteins that derive blood vessel development, and they push neurons out of the way. There aren't neurons inside of the lesion. So we know for AVMs, we know for cavernous malformations, there's not neural tissue inside of them. The second thing is, as a physician, when Dr. Scott operated, when we look at our pictures for the operating room, what we see different from the scientist is that these lesions tend to follow venous and capillary anatomy, these cavernous malformations, and they don't have intervening brain tissue. So the same thing that the scientist sees in their cell cultures is what we see as surgeons in the operating room with CCMs. And so Dr. Scott always used to say, hey, Ed, if you have this observation, is it important? How might it relate to what you're doing? And so one thing that has been found from the science world is that if you have this Ephrin B4 and Ephrin B2, the good guy and the bad guy, the ligand and the receptor, normally they exist in balance. And like all things in nature, if that balance is off, that can lead to disease. And what people have found is that with certain mouse models, with certain cell models, if there's this imbalance where there's too much Ephrin B2 and less Ephrin B4, that imbalance between receptor and ligand can create abnormal endothelial cells, which can lead to disease. And so what I want to show you here is that, you know, this science stuff might be important because when the scientist sees a molecule that's quantifiable, the physician sees something that might be diagnostic, a tool. When the scientist sees something they can manipulate in a petri dish, we see an option for a therapy, a drug. And we showed that before with the ROCK inhibitors, for example. And then lastly, if you can sort of see a response to changing these things, this might help us with long-term surveillance. For example, I've talked in the past about the idea of urinary biomarkers. For those of you that are wide awake or for other parts of the world going to sleep, I comedically label the urinary biomarkers in yellow as a little urine joke in the middle of the talk here, just to get a laugh or two. But I can't tell that over Zoom, so I'm going to assume you're all laughing hysterically with the urine joke. We've published this before where we have had urine biomarkers. You say, why the heck do you use urine? Well, it's cheap, it's easy, everybody pees, there's no needles involved. You can ship it anywhere in the world, and it allows a certain degree of specificity and sensitivity that you can't get from an MRI, not to replace MRIs, but to complement them. And this really relies on the biology behind these tumors and vascular malformation that you can see here. So we published this, and we had this idea that if you can have these potential markers, is it possible that in cavernous malformations, you might have the same imbalance? And if so, could you measure it and use that to understand the disease state? And so in a normal world, if the Ephrin B2 and B4 are in balance, we're hypothesizing that in the cavernous malformation world, there's more Ephrin B2, more of the stimulus, and that leads to an imbalanced growth that creates these malformations. So we looked at this, and this is just an example of why this is important. These are regular blood vessel cells on a camera, and each individual cell is marked, and we watch them over time to see how much they move. And normal blood vessel cells from the brain will just kind of stay in one area and do their own thing. Whereas we look at patient samples from cavernous malformations, you can see that these blood vessel cells go bananas. That's the fancy Harvard term again, but they move all over the place. And this increased motility, as you might imagine, directly relates to the fact that instead of a nice tight capillary like you or I might have in a healthy brain, the cavernous malformation capillaries are moved all over. They're stretchy, they're big. This is the exact phenomenon we're seeing on a petri dish that make those bubbles that we have to treat as surgeons in the operating room. This is also seen when we look at the actual tissue. So if we cut out cavernous malformations and we look at the ratio of Ephrin B2 to Ephrin B4 in the tissue, what you see is that in cavernous malformations, there's a way more balance towards the bad Ephrin B2. It's hugely imbalanced. So we'll be able to show that our hypothesis that we had from science is actually present in genuine patient tissue and patient samples. And this is pretty important because it suggests that this might be an opportunity to intervene. Why does this happen? So the next question people ask is, okay, Ed, that's really cool. You've got this hypothesis that these, proteins are involved in the growth of cavernous malformations. They create these abnormal bubbles that we treat at surgery. But why is it happening in the first place? What makes this start? And so I want to show you here, and again, this is my last sort of heavy science thing, but here's that Ephrin B4 receptor we talked about on the surface. This is what Ephrin B2 binds to. But Ephrin B4 controls this big, long pathway of molecules that end up moving the cell around and making it stick. So why do we care about this? Well, if we look at other vascular malformations, like vein of Galen malformations, about a third of them will have a mutation in Ephrin B4, and you get these wacky, big, scary blood vessels in there. Similarly, we've published from as well another paper looking at RASA1 mutations, and these guys get big spinal and brain dural AV fistulas, but also get cavernous malformations. And this is the next step down in the same pathway. This is another example of how a clinical observation, what you see when you say, hey, these kids come in, they all have this kind of syndromic vascular appearance. They're getting CCMs, they're getting, these high flow fistulas. Are they related? Well, now we're starting to understand why, which can lead to treatments. When we looked at cavernous malformations, this is a paper that just came out a couple of months ago, we found that there are similar Ephrin mutations in cavernous malformations, and these are from direct patient samples, further supporting the idea that there is a spectrum of cerebral vascular disease that can be all tied into a common pathway where there's a convergence between the ephrins and the CCMs, which end up on the same kinases and suggest there may be druggable treatments in there. We, again, as you heard from the initial presentation, we are now able to put together essentially a taxonomy, a list of the key genes that seem to be related to the development of these cavernous malformations. So we've got the sort of the key players here. CCM1, 2, and 3 have been known for a couple of decades. Ephrin B4 is one of the new exciting ones sort of coming out of the works in the last 2 years or so. This is the MAP3K3, which is one of the N pathway ones that is sort of a bad actor that we've seen with CCM3 in particular, mTOR, which is an important drug target, PIK3CA. This is a mutation that we see in a lot of developmental venous anomalies that may be helping to drive the formation of cavernous malformations and is druggable. And then RASA1 that I just showed you that have these cavernous malformations, and then the Rho-associated kinase, ROCK. And this is an incredibly important drug target as it's at the end of the pathway of many of these different molecules here, as well as I showed you in that diagram. So this seems a little nerdy, but I think it's incredibly important because this is the future of our field. This is understanding these malformations. It's easy enough to say, well, they bleed this frequently. Here's where they are in the brain. Should you take them out or not? What are some advances with lit or ultrasound or different treatments? But understanding that root cause, I think, will lead this to be druggable targets in the future in a way that we are leading, I think, the translational push in neurosurgery. At the end of the day, what we're understanding from our clinical observations, what we see in the operating room is helping us to understand that in this common pathway, a loss of function of Ephrin B4 or RASA1, or an increase of these kinases such as KRAS, we see them in AVMs, we see them in some cavernous malformations, BRAF, we see that in AVMs and also in some tumors, ends up at this common pathway down here. And this is important, for example, because you can use trametinib. And this is a drug that's being used for some AVMs. We can think about the common pathway coming in here with the ERKs and thinking about ROCK inhibitors and different drugs that may help us to treat these lesions in ways that if we can't get to them surgically, we might be able to treat them medically. At the end of the day, what I'm hoping we as a field can move towards is this strategy where we will be smart in making the diagnosis. And that can be with imaging, that may be with biomarkers, whether the urine, serum, spinal fluid, whatever. And once we have that diagnosis, in addition to the prognostic information we get from the natural history studies, like I presented at the beginning of the talk, we can do next generation sequencing. Knowing what these genes are, understanding what their pathways are, will allow us, I think, to not only have sort of the diagnostic sense of how you tie the genotype to the phenotype, what do the mutations end up presenting these patients like? Can we speak to them more intelligently? When you have a patient comes in your office, knowing that the genotype of CCM3 is going to be more aggressive, knowing that that might affect their gut, understanding that microbiome might affect them more, That's all stuff that we now know because of our genetic studies that informs our surgical practice. And at the end of the day, that information, I hope, will allow us to better understand who should we operate on, how safe or unsafe might that surgery be, and can we develop drugs that might treat this in a way that we couldn't before. So I really think it's exciting that we're in the forefront of this as neurosurgeons, and that this being fueled by our observations in the operating room anywhere around the world, and this is going to change, I think, how we treat these kids. So what can we say in conclusion here, in terms of the real wealth of information that is coming on cavernous malformations? People say, well, gee, Ed, that's not a very exciting talk to give. You're just going to say, if you can reach it, cut it out. If you can't live with it, or radiate it. And that was the practice maybe a decade or so ago, but it is markedly different now. Cavernous malformations are a significant healthcare burden, right? 1 out of 200 people have one in their brain somewhere. So this affects people all around the world. In particular for kids, this is something where we need to bring in multiple disciplines. And I think there's a lot of room to be made for surgical advances, whether they're just something as simple as using an ultrasound to as, resource intense as 3D modeling, to ultimately things like focused ultrasound, radiation, or lit. But at the end of the day, this is a surgical disease for the time being. And as such, understanding the risk of bleeding, who's recurrent bleeding, the fact that we should be more aggressive about treating patients with epilepsy, that we don't necessarily need to take out all the hemosiderin. We need to be careful about the developmental venous anomaly. These are all advances we can make right now, but I think fuel our future of treating this down the road. Stratifying our risk through these population studies, adding in things like genetic testing and biomarkers, I think is going to be so helpful in clarifying the best treatment plan for individual patients. And I realize these resources aren't available to everybody everywhere, but certainly the fact that even knowing they exist might help us to know which patients you try to go the extra mile for to, get that testing, get that understanding, versus which are the ones you can safely treat and just, hopefully cure. Um, Ultimately, kids with cavernous malformations are going to benefit from novel approaches in treatment. I've talked, I think, a little bit today about the operative techniques, the operative indications, and I'm particularly excited for this field about the way that the rapid advancement of molecular biology, and including with that, the other technologies such as increased visualization, increased training tools such as 3D printing, simulation, these are all really coming to a head to improve the treatment of these kids in a way that is so different, not even when I started my practice, but just in the past decade or so. I will say that all of us here, and I want to congratulate Naren for creating this listserv. I think we have an obligation as a team of people that are at the forefront of caring for these to push the field forward. We need to understand the risk. We need to understand the natural history. We need to understand the molecular biology, and whether we're treating them just as operative cases, or whether we're engaging in translational research with colleagues locally or around the world, I think it is our responsibility to really understand what these lesions are, how they affect the patients entrusted to our care, and with that trust, do what we can to advance the field forward and try to treat these patients with the best knowledge that we humanly have available. So I am very grateful for the opportunity to speak with you today. I hope I've been able to marry a little bit of at least what I hope to know is the state of the art for the population-based studies, the genetic background, the treatment modalities, the indications for treatment, and the current national guidelines, at least here in the US, and marry that with some of the science and why this is so exciting and how I think the field is going to change for all of us in the next few years, I hope for the better. So again, I thank you very much for your attention and your kind, focus on this. I hope that this was helpful to discuss, and I'd be happy to open the field up for questions now.
Thank you very much, Dr. Smith, for that fantastic talk. As you said, that Cavernoma is kind of a poster child. I think if we can somehow go from surgery to medically treating it, then that will pave the path for other uh, more complex lesions. And thanks for taking us through the clinical, the operative techniques, the adjuncts, new adjuncts, and also the basic science. I think it's a fantastic lecture. Thank you very much. If anyone has questions for Dr. Smith, please put them on the chat box and I will bring you up to ask the question yourself. But I have got a few questions in the meantime, Dr. Smith, and as you know by now that I have always few questions.
Yes.
Um, in terms of the latest WHO classification, is the cavernous malformation a vascular lesion or is it a tumor? Where are we in terms of what it actually is?
So we were just there was the in the US and internationally there's a group called the Angioma Alliance or the Coalition to Cure Cavernous Malformations, and we had our annual meeting in July in Toronto, followed by the IPSO, the International Pediatric Stroke Organization. And I will tell you that this remains a very hotly contested area of discussion, with some people saying that these behave very much like tumors in the sense that they have disordered growth. There's angiogenesis, and some of the molecules involved are essentially tumorigenic. On the other hand, it's hard to deny that these are predominantly endothelial cell-based lesions, or lesions undergoing EMT, endothelial to mesenchymal transformation. And so I think that at least as far as I understand it, it is up for debate. But I think most people would refer to these as vascular malformations with tumor-like qualities. But if that's a wishy-washy answer, I guess that's the poster child for it. But that's where I would put it right now, as far as I understand the current state of classification.
That's great. There are lots of questions for you on the chat box. I'm just going to bring them to ask the questions. Dr. Lucas, are you able to unmute yourself? Um, so while Dr. Lucas is trying to unmute himself, I've got one more question a few more questions, but next one. And the one of the striking things about cavernous malformation that we see is the venous anomaly. And is there any idea why that is there, and in terms of the risks of any injury to that? Thanks.
Yeah, so that's a great question. It's another area that's really evolved recently. So the question is, what about developmental venous anomalies? So just in terms of numbers, and correct me if you find anything different, but my recollection is about 7% of people in the world will have a DVA just independently. Of all DVAs found, about 7% of those, so 7 and 7, will have a cavernous malformation somewhere in there. So the first point is, if you see a DVA, think about a CCM. Almost always the DVAs that are found with CCMs are spontaneous, so they're sporadic somatic mutations, not the genetic mutations. And the reason that's important to your point, Aaron, is that the one of the leading thoughts in a certain small number of studies is that many of the DVAs seem to have PIK3CA mutations in them, so they're basically churning out metabolites. They're a fuel source. And one of the thoughts is, if there's a CCM nearby, there is this symbiotic relationship between the DVA and the CCM, where the PIK3C mutation is essentially fueling the growth of the CCM, with shared cells going between them, promulgating the growth. And so this may be one explanation as to why sporadic CCMs with DVAs tend to be a little more aggressive. So that's the background molecular pathophysiology. To your second question, I think, or second part of that, which is, what about with surgery? What about taking it out? It used to be thought, and I think some people still do think, that if you take out the DVA, there's going to be a big venous infarction and bad things will happen. I think increasingly the sense is, you shouldn't take out the DVA just for the sake of taking out the DVA. And in fact, if the DVA is draining normal brain, you're absolutely at risk of causing a big venous infarction. On the other hand, some of the tips of the DVA, if you think about it like a hydra, like what these are described, it is necessary to cauterize some of the tips around what's draining the CCM, because that's what's draining the CCM. So in short, I guess my understanding of the current literature in terms of clinical management is, in contrast to the past where they were avoided like the plague, I think you can take a small amount of the DVA out if it's related to the CCM, but you probably should not go after the main trunk or cause the DVA to be completely obliterated, because then you can get a venous infarction. Does that answer the question a little bit in terms of biology and surgical technique?
That's great. Thank you very much. That did answer. Thank you very much. I'm just going to read out the questions on the chat box. But before I go there, I just wanted to let all the participants know at the end of the Q&A, I will post the link to the feedback. And if you provide the feedback, then you will get all the certificate, the quiz, and the recorded video, and as well as the transcript. So please bear with me to the end. So Dr. Lucas Antkowiak, he's from Silesia in Katowice in Poland. So he's asking that in regarding the hemosiderin rim, and he's asking what's your experience in terms of when you had to remove it, and does it actually influence the seizure control? I think you mentioned about the seizure control, but have you removed it, and what had been your experience? If you could please read.
Yeah, so I think, at least what I was taught in my training initially was that you had to be aggressive and take out the entirety, if you could, of the hemosiderin rim to minimize seizure control. I think what we're finding, both from our own personal series at Children's, but also from some meta-analyses and other studies, and then this is reviewed in both the American Heart Association guidelines and some of the other articles we've written, is that probably do not need to be aggressive about taking out the hemosiderin rim. Across the board, as I mentioned, for most of these kids that present with seizure, you will get an 80% or better, either cure or marked reduction in seizures just with lesionectomy alone, so not chasing the hemosiderin. Obviously, if you have the opportunity and it's in a safe part of the brain, the anterior right frontal pole or something like that, it's probably some degree of irritation from that. But by and large, I think that at least the more current reports that I've seen and we've written about would suggest that you do not need to be as aggressive around the hemosiderin rim as used to be thought. And you can probably leave it behind with the understanding that if, they're in the 80+% that gets cured of their seizures, you're all done. You can just leave it be. Whereas if they're the rare, 1 in 5 or 1 in 10 that continues to have seizures, then you could continue with an adjunctive therapy. And that probably would involve, a seizure operation, either with ECOG or with LIT or whatever you use for, more disseminated seizures. We think this is related in part to kindling. And again, I'm not an epileptologist, so I'm speaking out of turn. Please yell at me. But by and large, that is the sort of current practice, I think, in many places in the US, is that you don't have to be that aggressive around the hemosiderin.
Thank you. Thank you very much. There's a question from Dr. D. Marcelo. Before regarding epilepsy, before I come to that question, let's say that if you have a patient who has come to you with a epilepsy and you see a cavernoma, how do you work that patient up? Do you do a full epilepsy workup? Would you presume that cavernoma is the cause, and you go for anti-epileptic before you go for the lesion? Could you
Right.
explain?
So great question. So the question is, a patient comes in with epilepsy or seizure, and they also have a cav mal. How do you work them up? Do you treat with medicine first, and then what do you do about surgery? So I would say, obviously, it's very contextual, right? So if you have a patient comes in and they have a cavernous malformation, and typically we'll start with an MRI and EEG. If the EEG captures kindling or epileptiform discharges that are in the same region of the brain as the cavernous malformation, and if the semiology of the seizures matches, right? If it's a right motor strip lesion and you've got left motor epilepsy, then that's probably all we would do. If it's a very complex seizure semiology, if we think that it might be absence seizures or something that might be multifocal, well, then we might do a more aggressive seizure workup and have the epilepsy team consulted for, long-term monitoring or whatever they feel is appropriate. So that's the start. Does the semiology match? Is there initial location match on EEG? And then that's either, if it says yes, then we would just presume operation. If it says no, then we'd send them to an epilepsy team for detailed monitoring. To your next question, would we start with medication first? A little bit of that is family preference, and a little bit of that is location. So if you have the new guidelines, I think that will be coming out from the Angioma Alliance this upcoming year, I think is going to be different than the prior ones in which previously we said if you only had a single seizure or two and you had a lesion, that the first line therapy would be medical therapy, anti-seizure medicine, and not necessarily surgery. In contrast, I think more of the data that's come out, some of this has been by Chris Ogilvie and others, has suggested that early aggressive resection is probably better in the long term, particularly in children, for long-term seizure control and protection. So I do think that while we will listen to the family and if the cavernous malformation is in a tricky spot or if the family's really averse to surgery, we will treat them with medication. But now, unlike before, we tend to be a lot more proactive in saying, look, even if you've only had one or two seizures, we probably would recommend taking this out if it's in a reasonably safe location, because most surgical series have a very low complication rate, and the new data would suggest that you would have a much higher likelihood of long-term seizure prophylaxis and being medication-free after surgical resection. So I think those are my two sort of caveated answers to your questions. Did I miss anything in that before I go to the next one?
Oh, absolutely on the spot. I was reading your article in New England Journal of Medicine. I thought I read that if you operate later with cases, then you reduce the seizures. But if you operate early on in AVMs, sorry, in cavernomas, you can increase the risk of seizures. Is that cases where they are not already have epilepsy or already don't have seizures? Am I
Uh,
getting it right?
I don't have the article in front of me. I don't remember that part specifically, but I would comment that the one thing that is a little bit of an important factor is the if they've had a recent bleed, and that can increase the irritation and risk of perioperative seizure if we think the child is safe, so they're not having mass effect or concerns. I saw in the chat someone mentioned the giant brain cavernomas, which is a good point. They're rare, but can happen particularly in younger kids. It is our practice, at least, to try to wait several weeks, a month or two, to let the cavernoma shrivel down so that you have less irritation to the surrounding brain. You have a more encapsulated lesion, and you can use that, as all of you know, I imagine, from the surgical approach to minimize trauma on the surrounding brain. So in terms of seizure activity, it may be helpful to wait a little bit to let that natural clot retract and have a better view of your lesion, less irritation to the brain, and a higher likelihood of a cure with resection.
That's brilliant, thanks. So the question that Dr. D. Marcelo asked is, in your opinion, laser ablation is a good option in epilepsy cases?
Yes, so this is one of the more exciting areas, I think, in recent advances. And when people talk about laser ablation, lit, Dr. Stone, Skellig Stone at our place does a ton of these, and it's increasingly become common. I think when we talk to our epilepsy group, when I talk to Skellig, there's really two reasons to use lit. So one, which I think is much less accepted and validated, and might still have a role, is for actual ablation of the cavernous malformation to try to shrivel it up and cure it. I think there's some nervousness around this, particularly with larger lesions, the fact that they're vascular, even though they're not like an AVM or an aneurysm, obviously. But there is some growing enthusiasm around using lit as an ablative treatment for deep lesions that are small, basal ganglia lesions, things like that. So that, I think, is an area in evolution when you talk about lit for ablative treatment, typically deep, typically small. In contrast to what I think the core of the question is, which is about epilepsy, when I speak to Skellig and other folks that do this routinely, the epilepsy surgeons, what they talk about with lit is the first thing, like a tumor surgery or anything else, is to remove the offending lesion. And so lit is probably a secondary line where if you the first goal should be to remove the lesion, do a lesionectomy. As long as it's surgically accessible, the caveats I mentioned in the talk, probably the best thing to do is just take the lesion out, not use lit, and see if that cures the epilepsy. On the other hand, if the epilepsy is not cured, or if the lesion is in an inaccessible place, the role for lit goes way up because then you may use it essentially as a firewall, as is done with a lot of epilepsy cases, because the presumption is the cavernous malformation itself is not the seizure generator. It is tissue around the cavernous malformation that is either under mass effect, has been hypoxic, has been, chemically damaged, whether it's hemosiderin or something else. And that's where lit can zap the tissue in the perilesional part of the brain. But if you take the lesion out, that's probably first line. Lit would probably be second line if that failed. So that's my long-winded answer to that, if that helps.
Thank you. And just to clarify in terms of when you say ablative, that you mean just zapping it, just coagulating with the laser. Is that what you mean by that?
Yeah, that's my technical term, zapping. Yes, that's the big fancy Harvard Medical School term. And again, I don't do these, but thermal ablation of the lesion, I think, is how smarter Skellig might say than me. So, but yes, the idea is to kill the lesion through the heat generated by the laser, in contrast to the more traditional role of doing seizure treatment around it. So, does that help?
Absolutely, thanks. And you touched on giant cavernomas.
Mhm.
And in your experience with giant cavernomas, how have you managed them?
To be honest, we've only had a few, and in general, our treatment strategy has been to take them out if they have mass effect. The key things are obviously blood loss and having an adequate exposure. We've been very aggressive. Both what I tell the trainees are two things. One, you got to have a big exposure. My joke line at work is you can compromise on love, but you can't compromise on exposure. So being able to see everything and access. So a big craniotomy. And the second thing is we've become very big fans of using tranexamic acid or TXA. Susan Gooby, who's one of our anesthetists, has really been an advocate for this, has done multiple clinical trials, usually first in craniofacial cases to reduce blood loss in kids, but this is translated over to some of our bigger tumor and cav mal cases. And I do find that TXA can be a helpful adjunct to reduce bleeding in these very large lesions. So those are probably the two more important points that at least our limited experience have had. But I think you'll see that there's a paper in the chat, and so you've got some of the experts right there online as well.
That's great, thanks. And in terms of, whenever there's an MDT of a cavanoma in a difficult place or large, I usually like to throw this, one or two papers I came across about use of propranolol. Has it actually been, where do your department or your practice stand on the use of beta blockers or in cavernomas?
So I don't use them very often. Frankly, if there's the only real time for that is if it's a deep brainstem lesion that we can't reach and they don't want radiation, or if it's a giant one that's tough to control. I will comment that there's some research that with propranolol, there are two enantiomers of it, a left and a right, and it may be that one of the enantiomers is more effective on the anti-growth potential of the cavernous malformations. Unfortunately, the drug companies, at least to date, have not been excited about purifying just I forget if it's the left or the right enantiomer, but for therapy trials. So I would comment that I think my experience with the efficacy of this has been fairly limited. So I'm not a big fan of it, but it is there if you're really stuck in a tight spot. If you can, you may reach out to some of the companies that produce it, and it is in a couple of papers where it's talked about which enantiomer is better. And I'm sorry, I just can't remember if it's left or right off the top of my head. Dr. Joyce Bischoff is one of the folks that has published some of the basic science around the mechanisms behind this. So if you want to look up some of her work, she would be a good resource for that.
Thank you. Let's say that a patient comes with a multiple cavernoma. How do you approach those patients, um, Dr. Smith? It happens time to
Yeah.
time.
So multiple cavernomas, we see that a lot in terms of the familial groups, right? So basically, there's three big things, which is first is workup. So we will typically get the brain scan. If they have multiple cavernomas, we'll refer them to a geneticist, and they will determine, as you know, sometimes these can happen in the eyes as well in the familial cases. So they will look for eye screening, and then they will get genetic testing and see if there's any other family members at risk. Nearly all of the multiple cavernomas are familial in nature, unless they're post-radiation, right? Those kids are a little bit different when they've had post-radiation. If it's post-radiation, one thing to think about is that some of these may not be cavernomas, but pathology has shown that a number of them are just thrombosed little veins. So that's an important thing to think about. So that's the workup. The second thing is after the workup, the surgical questions are, well, should you treat these or not? And what I usually tell parents is, look, these are going to generally change in size and even bleeding rates a little bit from time to time. And it's a little bit an arbitrary number, but I say I will allow a 5 to 10% change in size over time. Some will get bigger, some will get smaller. My rationale for surgical resection are the same as pretty much any other one, which is, are they causing symptoms from mass effect? Are they demonstrating multiple repeated bleeds and growth over serial scans such that we know in a child that this will become a problem down the road? That's that clustering effect I've talked about. Or are there seizures that are tightly localized to this lesion where surgery may help? One of the problems with surgery in multiple lesions is they become an annuity, right? You can chase your tail and do 1,000 operations. So I do tend to be fairly conservative and try to limit my operations on these kids because you can really, rob Peter to pay Paul. The last thing that I tell the trainees on these is, if you do have to operate on a kid with multiple cavernomas, it sounds trivial, but it's really not. Really thinking about your skin incision so that you can have flexibility if you have to operate on a different lesion in the future that might be in a different location. If you have some little linear cockamamie incision, and then, a couple of years later, you got to go to something that's kind of nearby, and all of a sudden you have a T-shaped incision or compromised vascular flaps, that's a real disaster. And I'm sure all of us have had different cases that have come in where we kind of curse the prior surgeon for their incision choice. I'm sure I've been the cause of that problem for some people too. But it is certainly a very important thing with multiple cav mals that is not thought about enough, but I do think merits discussion. So that's the workup, my reasons, indications for surgery, and then just a little comment about the technical application of operating.
That's great. Thanks. The other question is that I think on reading your article, fantastic article, I recommend everyone to read it. I think about 15% of the patients with solitary cavernomas might have one of these CCM 1, 2, or 3, if my memory is right. Do you send the cavernomas to for testing for these when let's say that you had a solitary cavernoma, you have excised it. Is there any routine testing for them or not?
No, if it's a single lesion and the rest of the inner axis is clean, because we will have scanned them prior to surgery, we generally do not do genetic testing simply because, the likelihood of finding, a familial mutation, there might be mutation within the lesion itself, a somatic mutation, but a germline mutation is vanishingly rare. So at least so far, it has not been either cost or clinically effective. So we haven't done it unless there's a specific odd thing about it or we're not sure about the way that it looks. So it's not part of our routine practice. We will do it on a case-to-case basis.
Coming to the last two questions. In terms, you mentioned that when there's a familial cavernoma, it can happen in the eye. Do the solitary cavernomas Do any other part of the body that occurs?
My understanding from our vascular biology group is you can have cavernomas pretty much anywhere there's capillaries. So they can occur. It's just that they simply are much less sort of worried about or seen. They do have a different cell of origin, right? Most of them are the brain ones we see are human brain endothelial cells, but they can occur in other places as well. So it can occur in lots of organ systems. It's just that the symptomatic ones tend to be the brain ones and rarely the eye ones.
Thanks. The final question, in terms of the radiation therapy, we say that radiation induces cavernomas, and then there's this treatment with presumed stereotactic radiotherapy. Has there been any long-term outcome to see whether these stereotactic radiation therapies, them itself causes cavernomas?
Does radiation cause cavernomas? Yeah, I mean, so about I think 3 to 5%. There was a nice paper by Nikki Ulrich, one of our colleagues here at Harvard, who looked at brain tumor patients that received radiation therapy, and both whole brain and stereotactic. And there's a separate paper she wrote about proton as well for those that use proton therapy. And I'm quoting a little bit out of school because I'm doing it by memory, but I think she said about 5% of patients will have some vascular anomaly. Now, that vascular anomaly could be a cav-mal, could be thrombosis, could be moya-moya. So it's a very broad bucket. But of those, I think, and again, I look at the papers to remind me, but I think it's about 1 to 2% will potentially develop something that is radiographically called a cavernoma after radiation. Now, some of the recent work, and I think this was mentioned in the New England Journal article, what historically radiologists thought were true cavernomas after radiation may in fact be just thrombosed veins. So particularly in the brainstem and midline fields, this is especially common in kids that have had craniopharyngiomas or adenomas that need midline therapy in their face. They'll have a very common brainstem, pons, midbrain, vascular lesions. But what they think now may be happening based on some autopsy studies is that there's multiple little venules in there. Those venules are sclerosed by the radiation, and the blood gets backed up. It has a little local microbleed, and that hemosiderin bloom is what is perceived as a cavernoma, but is really just sort of a vasculitis. There are true cavernous malformations with sinusoidal channels, mutations in them. They've been seen with CCM1 mutation, for example. So absolutely real ones can happen in association with radiation, usually very short, within a few years after treatment. But it may be that some of these may be a fake out from just microthrombosis. So that's a very long-winded answer, but I hope it clarifies things a little.
Very helpful, thanks. But in terms of the stereotactic radiation for cavernomas, don't is there any danger that them itself causes cavernomas in future, or is it too early?
Oh, so are you asking if you have a cavernoma in the brainstem, you zap it with stereotactic radiosurgery, could that treat that one, but then in the future create other ones? Yeah, I don't know that I know any data that would say that specific, because there's so few that are treated with stereotactic radiosurgery. It does seem to be effective in terms of treating them. I don't know the long term, are you robbing Peter to pay Paul specifically for those? So you stumped me with a hard one at the end that I'm afraid I can't answer. But all the other ones, I hope I gave a little bit of information.
Fabulous. Thank you so much for answering all those questions. That has been a fantastic lecture, and also I certainly learned from a lot from the Q&A. And once again, I first of all, I'm just put the feedback form, and I have asked feedback all on Dr. Smith and not on me. And and if you fill the feedback form, you will get automatically within a minute, the certificate will be sent to you and with a link to the quiz. And then I will send you the link to the interactive video and also the transcript, if that's okay with you, Dr. Smith. And thank you very much to all the participants for joining today. I'm very grateful, and thank you very much, Dr. Smith, for this fantastic lecture and also clarifying so many points for us. We look forward to having you again soon and wishing you a great time in Nepal.
Thank
Uh,
you. Well, it's been a pleasure, and I really want to congratulate you for manning this forum. It's absolutely wonderful. It's a valuable resource, and you've done an amazing job. So thank you, and thanks to everybody for engaging. I hope you all have a great rest of your day.
Thank you very much. And if anyone has any questions in terms of certificates or that or this, please feel free to send me an email. Thank you very much. I'll
All
leave
right.
the webinar on for 10 minutes so you can all get the link. And after an hour, I will close the feedback form. Thank you very much. Bye for now.
Thank you. Bye
Thank
bye.
you. Bye.